Let's get 2 minutes on the clock and your time starts now. Andrea Diaz, a 65-year-old woman, presented to the primary care clinic with a chronic cough persisting for the last 6 months. She describes the cough as intermittently productive with occasional yellowish sputum and notes occasional wheezing. Andrea reports gradual onset of dyspnea on exertion over the same period. She denies any fever or chest pain. Her past medical history includes hypertension, for which she takes amlodipine 5 mg orally daily. She has a 20-year pack history of smoking, quitting 10 years ago. She denies any recent respiratory infections. On examination, you find her temperature is 36.9 degrees Celsius, blood pressure 140/85, heart rate of 82, resp rate of 18, oxygen saturations 95% on room air, and body mass index of 23.5. Question 2.1. What specific examination findings would you expect to find with serious causes of chronic cough? List 5 specific examination findings. Alright, time is up. Time for answers. So here we have lots of potential examination findings that we would be wanting to look for. And so, of course, some of these would be hemoptysis on coughing. Are they able to actually produce things like blood? That would obviously have us all a little bit worried if that was the case. Weight loss, decreased breath sounds, prolonged expiration, pedal or sacral edema, elevated jugular venous pressure, pulmonary crackles to auscultation of the chest, and yes, there can be multiple different findings related to auscultation findings on that. Basal dullness to auscultation of the chest, unilateral or bilateral. Again, I'd probably specify just one for the actual exam itself. Resonance to percussion of the thorax or lungs, bone pain, neurological deficits, clubbing of fingers, one of those signs of chronic hypoxia, lymphadenopathy, and of course, evidence of atopy, rash, or rhinorrhea. This is one of those things where often we get a bit caught up sometimes and may not know, what are they looking for here? Just think, if this patient was in front of me, what would be the things that I would actually be looking for? With that, you're going to find stacks of answers. So here from the chat, we've got dysphonia. Oh, excellent. Yeah, that's one that's not on here, but would definitely get you a mark. Hyperexpanded chest, tick. Clubbing, tick. Fever over 38, yes, definitely tick, and pedal edema, tick, tick, tick. Very well done. Also here we've got finger clubbing, reduced air entry, weight loss over 10%. Yep, another big tick there, definitely. And I really like how specific you've been as well. And peripheral edema, fantastic. Elevated JVP, definitely. Now we have a question here as well. I'm curious about examination for bone pain. Are you really checking all bones? You're not going to assess every single bone, but if you do happen to find that you examining them and they complain of pain through long bone or spine, you're going to be more concerned about things like myeloma or metastases into that space. And sometimes that can be one of the few findings you actually do elicit. So I think bone pain, if you were to specify spinal pain or metastatic bone pain, I think you'd definitely be getting a mark there. Hopefully that makes sense. All right. Of course, we've got question 2 on this case. Let's get 2 minutes on the clock and your time starts now. What investigations would help provide a definitive diagnosis? Select 4 investigations. Pulmonary function tests, spirometry. Electroencephalogram, EEG. full blood count, FBC, with differential, chest x-ray, thyroid function tests, stool culture, electrocardiogram, ECG, B-type natriuretic peptide, BNP, urinalysis, serum zinc. Alright, time is up and let's get to the answers. So these answers are taken from the RACGP guidelines on investigation of chronic cough. So as you're no doubt going to expect here, pulmonary function testing to investigate for pulmonary features, yeah, it's a bit of a no-brainer. So spirometry is going to get you 2 marks. It's going to be really good bang for buck there, so definitely worth the most marks of these options here. Of course, full blood count with differential is going to be looking at our inflammatory type pathologies. Chest x-ray is going to give you a lot of anatomical details there, and low-dose radiation, readily available, definitely going to be high yield. ECG will also score you a mark to help exclude cardiac causes or abnormal rhythms or perfusion. Can give you hints on cardiomegaly, for example, and so it's definitely going to be a mark. And B-type natriuretic peptide, again looking in that cardiac failure type picture, going to be giving you marks there. So as you've both correctly identified from the chat there, ADCH and ACDH, yep, agree, 100%. Now, again, look, we have 5 correct answers here, even though they've asked for 4. Always remember there's usually going to be more correct answers than options to select from, so don't trip yourself up and get caught up too much on that kind of thing when that happens. And there's very few times we need to check serum zinc. Just throwing it out there. It's not never, but few times. Of course, we've got another question here. Let's get 2 minutes on the clock, and your time starts now. After appropriate testing, a diagnosis of mild chronic obstructive pulmonary disease is made. In addition to non-pharmacological management, what pharmacological management would be appropriate? Provide one specific pharmacological management. Doses are not required. All right, time is up. Let's get to those answers there. So COPD, mild diagnosis. Our first line is going to be salbutamol, metered dose inhaler as required. Again, you're not expected to know the dosing here, but 1 to 200 micrograms by inhalation with spacer, 2 marks. And of course, instead of that, you could use terbutaline, dry powdered inhaler as required. Again, for mild disease, you start as required medication and see if they actually need to have a stepwise increase from there. This is both in accordance with the COPDX guidelines as well as ETG. So both those sources are going to give you the same answer there. So unfortunately, Spiriva, as we've got from chat here, is not going to be giving you a mark there. Sorry. Used to be pretty much most people would just start people on tiotropium or ipratropium. Nowadays we're saying start off with the other ones first. And as we've got here, can never recall whether LAMA or LABA is best first up. Yeah, fair enough. As a rule of thumb, if you get a bit trapped here, salbutamol is usually going to be a pretty safe answer, and so feel free to kind of start there and work your way up. All right, well done, guys. This one is one of those ones that I don't think we often see mild disease at diagnosis, and I think that's one thing that we often stumble on. So do be mindful that the severity of disease at diagnosis is going to have a definite impact on what pharmacotherapy we actually start them on, acknowledging that the vast majority of patients that we diagnose are probably going to be in that moderate or medium bracket. So have a read through the guidelines, make sure you're familiar with them for the exam. If you want to get into a little bit more detail as well, they say that start off with SABA or start off with basic things first and reassess after 3 months of therapy. So as much as they can, try and go for 3 months before deciding whether or not you're going to up-titrate there. And then, of course, you'd be upgrading to LABA or LAMA monotherapy.